the olaparib Durvalumab arm of the I-SPY2 trial asked the question whether we could improve the pathological complete response rate if we include these two additional drugs to standard of care chemotherapy. So the biological rationale behind adding immunotherapy and a PARP inhibitor to chemotherapy is that each of these modalities have been shown separately to synergize with chemotherapy drugs. There is very good data now from randomized trials that immunotherapy agents improve chemotherapy response rates and progression-free survival in many different settings. And part of the chemotherapy efficacy is mediated by the immune system. So the PARP inhibitors actually could increase the immunogenicity, at least in animal models of various cancers, including breast cancer. So that was the biological rationale behind the combination. So the I-SPY is a multi-arm Bayesian randomized trial with multiple arms running in parallel. The design is such that the better performing arms preferentially draw patients. The randomization is biased towards the arms which have the higher pathological CR rate. To be able to do that, you have to monitor the outcome continuously. So in I-SPY, the randomization is updated and each arm, trial arm, is tracked separately as the data is coming in. And the data includes the pathological complete response rate at the time of the surgery and MRI responses that we are also collecting at 2 weeks and also at 12 weeks. So a trial arm, could have 3 fates. It could fail because of futility if the predicted probability that the experimental arm is better than the control is less than 10%. Or it could graduate, which means in our sort of parlance is that the accrual stops if the likelihood that it would be better than the experimental arm in a future larger randomized trial is greater than 85%. And we also set a maximum number. So if an arm neither fails or graduates for success, then the maximum number that we would accrue is 75 patients. So the olaparib Durvalumab arm graduated with success after 73 patients were accrued. The final predicted pathological complete response rates were higher in all 3 of the biomarker groups that were pre-specified for the efficacy analysis. And these 3 groups are all HER2 positive cancers together and the 2 major subtypes of the HER2 negative. So all HER2 negative cancers together, and also the 2 major subtypes of the HER2 negative cancers, which is triple negative disease. And that was 22 patients and 51 patients who were ER positive, HER2 negative. So the pathological CR rates increased in all 3 of these groups when olaparib and Durvalumab was added. So there were no unexpected adverse events, but of course the 2 additional drugs did bring in additional adverse events that were expected. So the overall grade 3 or 4 toxicity rate was slightly higher, around 56% versus 48% in the experimental arm. And that's a preliminary analysis. So we don't have the complete toxicity data on all the 73 patients. So this is really a pretty early look at around 44 patients having complete toxicity results. But it's also fair to say that immune-related adverse events were about 19% in the experimental arm and 1.6% in the control arm. And these immune-related events are classical, known adverse events associated with immunotherapy, such as colitis and hypothyroidism and adrenal insufficiency. So the main conclusion is that immunotherapy definitely increases pathological complete response rate. We have known this for triple negative disease from many different studies, but the real remarkable finding in this and a previous I-SPY2 trial with pembrolizumab, that we see the improvement in pathological CR rates in ER-positive disease as well. And what was particularly encouraging in this trial, that our biomarker analysis identified a subset of the ER-positive patients who we think preferentially benefits from the combination. And that was the MammaPrint ultra-high group. So the MammaPrint ultra high group is the upper half of the MammaPrint scores or MammaPrint risk distribution. And all the benefit from including olaparib and Durvalumab was seen in that subset. And their pathological complete response rate was remarkably high, 64%. Whereas in the MammaPrint lower half group, still MammaPrint high, but not the ultra high group, there was no benefit whatsoever from the combination. And their pathological CR rates were low, around 10% in both the control and the experimental arm. So that really opens a new avenue for exploring and really capitalizing on the efficacy of immunotherapy in ER-positive disease. So I think the sort of immediate clinical impact is that it really adds to this building sort of data that supports the value of immunotherapy in the neoadjuvant setting in triple-negative disease. So in the United States, pembrolizumab is the only drug that's approved in that setting. But many other drugs in that with the same mechanism of action are now showing the same effect. So that really gives confidence for physicians that indeed the pathological complete response rates are increasing when immunotherapy is included. The longer-term goal, of course, is to really translate these results into ultimately registration trials in the ER-positive disease. And there are several large randomized trials that have been launched. So remember, the I-SPY is really a signal-finding study. So it's a relatively small randomized phase 2 trial whose purpose is to identify promising combinations. And I think we have done that. And we also identified the biomarker group where this combination is most likely to succeed in a large randomized trial. You know, that arm of I-SPY is closed. So I-SPY as a trial platform is, of course, going on, and there are 5 or 6 additional arms with different combinations. So what we expect as a follow-up is we would like to discuss the plans with AstraZeneca, the sponsor of this trial. So I also must add that from this design, it's unclear what the individual contribution of Durvalumab and olaparib are to the results. So we added 2 drugs to the standard of care chemotherapy, and the outcome improved. But which of the 2 drugs provide the major sort of efficacy benefit, or the 2 of them, both of them are required, or just one of them, is really cannot be teased out from this trial. So that's another important question also to address. Then what was the contribution of Durvalumab and what was the added value of olaparib? There is one question that comes up very often about the I-SPY design, and that's the statistics around the graduation, which is at least 85% probability of succeeding in a 300 patient randomized trial, and the final results that we usually present, and what I presented at AACR. These 2 pathological CR results are never the same, because the arms graduate when the predicted probability reaches the 85%, but many patients are still receiving treatment at that point. So the graduation simply means that the accrual stops. And at that point, that's the predicted pathological CR rate. When all the patients who already have been accrued and receiving treatment complete their treatment and they undergo surgery, then we have the final pathological CR results. And these final results are sometimes a little bit larger or a little bit smaller than what the graduation predicted PCR rate was. And that's exactly what actually we have seen and shown for this particular arm as well.